Kia ora tātou, ko ka puka tō mahaka te maunga, ko Samfly te awa, no ototahi hau, ko Muir tuko whānau, ko Rebecca tako ingoa. Kia ora everybody, my name is Rebecca Muir. Thank you all for joining in on my presentation today. I thought I'd begin by telling you a little bit about who I am. So I live in Christchurch, but I'm originally from Dunedin. I work for the Canterbury Clinical Network as a senior project facilitator. As part of my role, I work within the shared care planning team, which I've done so for the past 5 years. My role within this team involves supporting the development and refinement of shared care plans, as well as supporting the rollout and implementation of how they are used across the Canterbury health system. So today my presentation is looking at how we capture key information of vulnerable people during lockdown. So the way in which this was done was by using one of our shared care plans, which is available here in Canterbury. So I'll begin by telling you what shared care planning is. Well, it describes a way of working which involves community, primary and secondary health services working together to proactively manage and plan care for patients with complex health needs. It's a tool in which enables coordination, helps to improve communication between services and the real-time sharing of information. These plans can be accessed South Island-wide and can be created, updated and used across a number of different services, including emergency department, St John, primary care and specialty care services. So there are 3 shared care plans, which on this slide, I have a brief definition of each of them, which I won't run through. However, the point that I want to make here is that these 3 shared care plans serve different purposes. So you will see by reading the definitions that a patient may in fact have 1, 2, or all 3 shared care plans, depending on the complexity of their condition. So setting the scene. So from the first time a COVID-19 case was reported in New Zealand, which was February 28th, conversations began between a number of different teams, including the shared care planning team, the advanced care plan team, palliative care and acute services. These conversations were around how we could improve communication about acute management of vulnerable people in crisis situations. So by early March 2020, the planning began. There were growing concerns that the Canterbury health system could become overwhelmed with patients with COVID-19 symptoms. Preparation was required, particularly for patients who may contract COVID-19 symptoms, but also for those vulnerable people with already existing complex health conditions who may present acutely unwell during this time. There was a real urgency around finding a solution that would help to increase the visibility and communication of important conversations regarding these patients which were already taking place, as well as capturing key medical decisions for those patients who are at risk of health deterioration. So as we all know, on March 25th, New Zealand moved into alert level 4. So what was the chosen solution? Well, as I touched on in the previous slide, each of these plans serve very different purposes. We needed to ensure that decisions were captured in a timely manner and available to different clinicians. So a decision was made that the advanced care plan was not the most suitable tool at this point in time, given that there may be time constraints that clinicians may face during a potential outbreak. So the suggestion was made that the acute plan should be used to capture this information. So the reason for this is the acute plan is easy to write and update, and it would make patient preferences of care and treatment visible to a number of different clinicians. So what are the benefits of using an acute plan? Well, as you can tell by the slide, there are a number of benefits. So the acute plan has been being used by Canterbury clinicians since 2016, when it was made available on an electronic platform. So it was fair to say that a number of Canterbury clinicians were familiar with using the acute plan, but also with the concept of sharing information across services in an electronic manner. The acute plan captures key information which is valuable for acute teams. The plans are kept up to date and they're relevant to the patient. The plans can be used as a clinician-to-clinician communication tool, and it enables the secure information sharing between hospital, primary, and some community care providers. The plan can provide guidance to clinicians who may be unfamiliar with the patient. So remembering that we're looking at a potential crisis situation where there may be a huge increase in a number of people presenting acutely unwell, and the clinician may be unfamiliar with the person that's in front of them. So when a plan is created, a flag is generated in the electronic medical record. So this is indicating that a care plan is in place for that person, which for a time-poor clinician in a crisis situation, that can be very valuable. The plan can proactively support the communication of information for vulnerable cohorts of patients. So I've given the example here of people receiving palliative care in the community. So which patients? Well, we were encouraging the plans to be put in place for anyone a clinician would normally consider writing an acute plan or an advanced care plan for. It was for vulnerable patients who are likely to or might present acutely to emergency services, and also those who are at risk of serious infection of COVID-19. So what did we do? Well, we set up processes for notifying, educating, and supporting staff. This was to ensure that the plans were being used consistently across services, as well as providing refresh information around how to use the acute plan. Guidelines were created, which also supported the education component. Communication was individualised, and what I mean by this is the information that got sent out to different services was tweaked slightly depending on the audience. So the information that went out to general practice varied slightly to what was sent out to hospital services. Communication was individualised. Information was sent out through multiple channels, and information was updated on our community and hospital health pathways. We also ensured that project teams stayed connected. So where was the information captured? So the two images that you have in front of you is what it looks like when creating an acute plan and what a completed acute plan looks like. So we encouraged clinicians to put information in the top key issues field. So this was visible immediately when a clinician clicked into a plan. As well as encouraging this information to be captured here, we shared the Health Quality and Safety Commission Talking COVID resources. We also encouraged the use of the Serious Illness Conversation Guide and the Shared Goals of Care framework. So what were the outcomes? Well, as you can see by this graph, which is capturing the total number of acute plans created system-wide, we saw a huge spike in the months of April and May. In fact, we saw a 400% increase of the creation of acute plans alone in April compared to March 2020. Of these new care plans that were created, we've done a recent audit just to check the quality of the plans, the type of information that was being captured, and who was the authors of these plans. So the audit showed us that it was a real mix of clinicians across the system that were creating the plans. I've listed a few examples there. What we also saw is that clinicians were capturing patients' preferences in key medical conditions in that top field, which is on the couple of slides back. But they were also contributing to other fields in the acute plan, which was really fantastic to see because it meant they were getting a full picture of the patient. So again, this is looking at acute plans updated across the system. So like the previous slide, we saw a large increase of the number of plans updated during April and May. So this showed us that those plans that were created prior to COVID, clinicians were actually going in and updating these to reflect current details and important information about that patient. We continued work around the promotion of the importance of keeping these plans updated, and we'll continue to do that in the future also. We looked at how many times plans were viewed. So this is what this graph is displaying. The total number of times an acute plan was clicked and opened. So we saw a 120% increase in the number of views across acute and primary care sites. We continued our everyday work around raising the profile of an acute plan. So what I mean by that is we continued to encourage people to simply go and have a look if they saw that a patient had the little flag, to go and click and open the plan and see what's in there, to become familiar with that process. We see that viewing a plan is just as important as creating them. So there were a few lessons learned throughout this process. So given the evolving and uncertain situation, we needed to ensure that our messaging that was going out was clear, concise, and provided in a timely manner. The work we were doing, we knew it had relevance to the other regions, given they too were using shared care plans. We saw the importance of not only working collaboratively across our teams, but also other teams across the South Island. So with that, we did share our processes with other DHBs, and they chose how they implemented that in their regions. We ensured that throughout this whole process, we continued to promote the acute plan's original purpose. And we knew that it was really important that these conversations were being captured. We knew they were already occurring. We were simply providing a place for these conversations to be written and shared across different services. So the final lesson learned for us, within Canterbury, there is funding attached to creating or updating shared care plans in general practice. So an unexpected implication we saw of the increase in plans created and updated was we subsequently saw a large increase in the number of claims that was coming through, which wasn't budgeted for, but we are now able to include that in our budgeting each year, in case the plans are to be used in another crisis situation. So a take-home message would be that following 4 years of the acute plan being used across the Canterbury health system, by simply doing a process like this, we have realised that this plan is really adaptable, particularly in a crisis situation. So we know that by implementing these processes, particularly in these urgent care teams, it has meant that when we go into a crisis situation, we can quickly get information out, and we don't have to spend a lot of time re-educating people on the process because it is already familiar to a number of clinicians. So I think for us, it's been really exciting to see the acute plan evolve in this way and to be used in such a meaningful way during a particularly difficult time. And I think there are a number of lessons learned that we'll take away from this. And we know that in future, we have a really adaptable tool that could be used in a number of situations for our people, not only in Canterbury, but across the South Island. Thank you all for your time, and I'll look forward to answering some questions during the Q&A session.